Yes.
Did you say we have a quiz today?
We do have a quiz today.
Oh, it's not showing in the module, so that's what I was asking.
Yeah, so I posted it in the announcement. So you'll never see the quizzes in the module. You can find them on the syllabus. We can't turn on the quiz until class. So otherwise you'd be able to take it before class. So all the quizzes this term will be taken during class time. It'll be like last week, except hopefully it's more organized because there's 2 sections. So if you're not in class, you can't take the quiz. That's part of the new policy for this term. So if any of your classmates are not here and you know them, you can let them know we're going to take the quiz at the end of class. And if they're not here, they will not be able to take it. Okay, so let's go ahead and get started. So this week is Chapter 22, Healthcare Adaptation. So this is starting to look at how we as nurses adapt to children being in the hospital and how we adapt our care to the family unit when they're in the hospital specifically, and also just kind of the family unit in general. So there are some very specific things when kids get admitted into the hospital that you need to do. So I know several of you work. Can you share with me what the nurse's responsibility is, generally speaking, on admission? What sorts of things does the nurse have to do right when a patient comes into the hospital?
Triage, assess the patient.
Very good. Make
verify.
Sure you know
and consent from the parent.
Get their background information, patient history.
Patient history.
The nurse advocate for the child.
Yep, nurse advocates for the child, absolutely. Get their background history, find out about their medications, what they took at home, what they're taking, any family history of genetic problems. And then who signs the consent for the child?
The parent.
Almost
or the legal
always,
guardian.
Yeah, almost always the parent. What sorts of pediatric patients can sign their own consent?
Emancipated pediatric codes.
Yeah, emancipated minors. Very good. So so all of what you said is true regarding an admission. So you're going to be communicating a lot with the parents, but always try to remember that the child is your patient, so you should be explaining things to the child also and using age-appropriate communication based on their developmental level. So I'm sure you guys know this, that all the patients in the hospital have to have an ID bracelet. And what about the parents? Do they get a bracelet too?
Yes.
Yeah, okay.
Yeah.
So then you can kind of see them from a distance, you know who's allowed to be there and who's not allowed to be there. So I'm going to ask you just a general question. Let's say you walk into the room and your 6-month-old patient is in the crib and her ID band is off. It's not on her, you can't find it. And you need to give her a medication and her parents are not there.
You get her a new ID band.
You get her a new ID band. And how are you going to verify that 6-month-old is in fact your patient?
Should you wait until the parents come back?
Yeah, so if that's possible, or talk to the charge nurse. In theory, the charge nurse should know who all the patients are in the unit. Maybe this has been your patient for a while and you know who it is, but you need to have some way of verifying that's the patient. And then do you make the ID band, or how do you get the ID band?
No, you should go back. Unit secretary does.
Yeah, the person who made or she made it.
Yeah, so sometimes in some hospitals the nurses can make them, but if it's the unit secretary, you don't have to send them all the way back down to admissions. You should be able to get them made in the unit. So, you know, young kids obviously are not in beds the same way that bigger kids and adults are. So what can you tell me about cribs? What some sort of safety precautions do you think apply to cribs?
The railings need to be up.
Railings need to be up. Do they have wheels on them? Can you lock
them?
No.
So some of them do. If they do, you need to make sure that they're locked. Okay. And who has heard of a bubble top or knows what a bubble top is?
It's for climbers, people that like climb out the crib.
Yeah. So a bubble top it's like a piece of clear plastic that sits on top of the crib. So then there's a hole in the center of the bubble top, so you can still get into the crib, but if you have a toddler that likes to crawl, they won't be able to crawl out of the tib. It's like a plastic top for the top of the crib. So those are common things that you're going to have to use if you're in a pediatric hospital.
So would you say that that's like a
toddler incubator?
Yeah, it's like a toddler incubator. Yes.
Okay.
Very much. Yes. So, other things, obviously kids, they like to put things in their mouth. They like to put their fingers in things. So there's lots of outlets and stuff like that in the hospital. You don't want them somewhere where they can put their finger in the outlets. And if you're giving medications and, like the oral syringes have those little caps, you need to make sure that all of that stuff is put away, that they can't choke on anything that you leave in the bed. And if they have any sort of infection and they have RSV or some sort of diarrhea illness or anything like that, you can't be like moving toys from room to room because you could spread infection. And then, oxygen. What sorts of things do we do to make oxygen more safe when we're in the hospital?
No smoking?
No smoking?
No stuffed animals or battery operated toys.
Okay. How about humidification? Is it just dry oxygen or is it?
No, it's humidified.
No,
It's humidified, like a mist.
Okay. And then do you put petroleum jelly around their nose?
Yes.
No.
It'll burn.
Oh no, it's a risk, right? Or like some type of
Yeah, it's flammable.
Yeah.
So you don't normally do that. Very good. So, we have different equipment in the hospital to move people around. So wheelchairs, stretchers, etc. Sometimes kids like to play on those things. So you just need to make sure that you're, having rules and guidelines for kids that they can't play on the hospital equipment. Obviously, you never want to leave a kid unattended in their high chair or anything like that. They need a lot of supervision. If their parents aren't in the room, sometimes you can ask for a sitter or somebody that comes in and just hangs out with them. So I think all of this stuff applies to any hospital, but, in children, you always worry about, them getting lost or being kidnapped or what have you. So always make sure that they're being transported safely. If they can walk, they should be able to walk to wherever they need to go. You can, in hospitals, a lot of times they have like wagons or pediatric sized wheelchairs that are kind of fun looking. So, and if they have to go in their bed, that the side rails are up, that they have their ID band on, and that the nurse is always documenting where they went and when they came back and who they went with. Alrighty, so you guys started talking about this when I asked you what happens in an admission, and you do get the basic data collection. So there's the history and physical. So there's the history part, and then there's the physical part. So we're going to start with kind of the youngest one, the infant. So what do you think is different about examining an infant, or some techniques that you should have as a nurse when you're doing a physical assessment on an infant?
Your touch, how you touching them.
Mm-hmm. What else?
You could have like a doll or something that you can play
How you
with.
speaking to them.
Yeah, something to distract them with, like a doll, how you're speaking to them. So they don't regulate their body temperature really well, especially when they're young. So you should make sure the room is warm. And somebody said talk softly. Yeah, you don't want to startle them. What do you think? Is a pacifier a good thing to have when you're going to go in and look at them?
Yes.
Or you could
You could what?
You can hold them.
Mm-hmm. So right, you want them as calm and relaxed throughout the exam as much as possible. So you're probably going to have to unwrap them a little bit to really look at them and listen to their heart and lungs. But then as soon as you can, you want to wrap them back up. You want to swaddle them. Yeah, I think you guys hit on all of those. So you're always going to be thinking about the child, baby, and their environment. And there's a lot that you can get from just observing them. So if at all possible, you should always take a step back and kind of look at the patient before you go in and start taking out your stethoscope and listening to their heart and lungs and all that. Just, are they dressed? Are they clean? Do they look like small for their age? Are they really overweight? Are they have any bruises? Are they playful? What are they doing? There's a lot of information that you can get just kind of from a few feet back and kind of looking at them. So never underestimate how much information you can get just from initial observation before you actually do the physical exam. So there are some things that, some sorts of infections and things like that that happen in kids that we don't necessarily see as often as in adults. So what do you think about a kid who's tipping his head and rubbing his ears? What might be wrong with that kid?
Ear infection.
Ear infections. Okay. And what is the main way that we treat ear infections?
With antibiotics.
Antibiotics.
Okay. And what's important, like if a child is prescribed amoxicillin for 7 days and the child feels better after 5 days, should the parent
Take
stop the
completely.
antibiotic?
No.
Take the whole thing.
You have to still do it.
Feel better.
And what sorts of things, like is amoxicillin kept in the refrigerator? Does it stay outside?
Yes.
What sorts of things
the
do you need?
In the fridge.
Fridge. Okay. And what are some techniques to get kids to take their medicine?
You can get the flavored kind, so that way it's
Yeah.
it won't be
Yeah.
so bad when they take it.
That's a good one. Talk to the pharmacist, get a flavored. Okay,
Yeah,
there's
tastes like bubble gum.
Play games with them. Like
play games with them. Like what
Mhm.
sorts of games?
and like an airplane or choo-choo train going in their mouth.
Oh,
or something
okay.
like-
Very nice. Very nice. Okay. So there's some specific things that, when you're tested, they're going to say that you don't do that I know a lot of people do, and I just want to point them out. So you don't mix it with like their milk. You don't want to put their medicine in their baby formula, because then if they don't eat all their baby formula, then they won't get all their medicine. You don't want to like shove it in their face when they're crying. Could choke. And you don't want to mix it with juice either, because it's the same thing. Then they might not drink all their juice. So they, all the things that you said are right. They generally say to use an oral syringe and put a couple drops in the side of their mouth. So it's usually not very much when they're little, and you can put a little in and then they'll swallow it. Sometimes you can kind of blow in their face and then they kind of startle and then they swallow. In an older kid, they recommend that you kind of bribe them. Hey, if you take your medicine, then you can get like this juice or something that tastes good when they're done. So you will be asked on your exam and kind of on the HESI-2s, like what sorts of techniques you would use for giving them medication.
You wouldn't say that it's candy though, right?
No, you don't want to lie to them. Yeah. So that's all for like ear infections and giving them their antibiotics. But there's other things that, and we kind of talked about, like if they're really rigid, they might be in pain or they might be uncomfortable. If you see bruises or cuts, you should be concerned. So when we talk about child abuse, like what's a red flag for child abuse when you're looking at a child?
Bruises.
Bruises, but like what specifically about bruises?
Pain.
When they looking scared.
When they're looking scared, yes, and when they have bruises that are what we say are in multiple stages of healing. So I don't know if you've ever like run or something, like sometimes they're purple and sometimes they're green. Go ahead.
Is it also when you have like bruises like that are not in places that they should be, like the basic places like knees or in the elbows are okay, because kids play around, they fall and stuff, but like on their neck or their back or something like that, they shouldn't have bruises. Yeah,
or even kind of, exactly. Like think about where kids fall or if they run into something, but right, it would be really unusual to, and also on the face, or on their back, places like that. And then also the various stages. Exactly. Very good.
Professor, I have a question.
Yeah.
So, when like as a nurse, we suspect, I cannot talk this morning. Suspect child abuse. We immediately, do we notify like authorities immediately, or do we talk to the parents? Like,
so you are, as a nurse, you are a mandatory reporter. So you are required to report. But it's one of those things that it kind of depends on how, serious the situation is. If the child's being admitted to the hospital and the kid's going to be there, you can go and talk to the charge nurse and let you know, and maybe the charge nurse can give you a few minutes so that you can file your report. But so you're always thinking about safety, if you're in a situation and you don't have time to talk to the charge nurse or whatever, try to isolate the child that you're worried about, say something like, we need to go get this lab done, so I'm going to take Johnny over to the lab. And then you can call, if you have to, you can call the police, but the agency that you report to is Child Protective Services. So as a nurse, you are a mandatory reporter.
So would we have like another nurse to just like basically evaluate it as well before we call Child Protective Services?
No, you don't have to have another nurse. The main thing is you really should be very, very clear about your documentation so that it's very clear if someone's going through and reading what you saw, why you were concerned.
Okay.
But you don't need someone else to validate your opinion or your concerns. You're still, you should still report.
Okay.
So, you know, aside from child abuse, when you're just doing your general assessment of a kid, you know, adults who always asked about like what medications they take, what they eat, who they live with, etc. There's some specific information that we get about kids in terms of their eating and their sleeping habits. Are they potty trained? What type of activity level they use? Or if the, you know, depending on what their vocabulary is and where they are with their speaking, if they have any special words or anything that they use. So you should be thinking about, you know, how getting that history about a kid is a little bit different than it is with an adult. So when you start doing the actual physical exam, you know, you're going to do the full body, head to toe. We talked about previously, you don't have to go specifically from head to toe. You know, if they're calm, that's a good time to listen to their heart and lungs. So you can adapt your physical exam to what they're doing, but you do need to review everything from head to toe.
I have a question.
Yes.
When a child is coming into like the emergency room or whatever, or just being admitted to the hospital, if the person bringing them is not their parent, it's like a caretaker or an adoptive parent or a foster parent or whatever, what do they do with the ID bands? Do they put the caretaker's name on it to match the child, or how does that work?
Yeah, as long as the person that brought them in is their guardian, then the guardian would still get the ID band.
Okay. And then would their information just match what's on the child's ID band? So that way you know that they're...
Yeah. So the hospital I worked at, it actually didn't have the parent's name. It had the kid's name and date of birth, and the ID band was a different color.
Oh, okay.
So yeah, we wouldn't have the parent's name. We would have the kid's name on the parent's ID.
Okay.
So we talked a little bit in the first week of class about vital signs. So heart rates and respiration. So kids, do they have a higher heart rate or a slower heart rate than adults?
Higher.
Okay. And then, you know, with adults, you usually just feel their radial pulse. How do you get the heart rate on a child under 5?
Apical pulse.
Yeah, really apical pulse. And what does that mean? What does it mean to get the apical pulse? How do you do that?
You do it for a full minute, like the face,
face. Yeah. So you're not feeling, right? You're listening with your stethoscope at their heart. Okay. And then the respiratory rate tends to be faster. And if at all possible, you should get their respiratory rate when they're calm. Otherwise, it can kind of throw your vital signs off. And then the blood pressure. So the same thing, is blood pressure higher or lower in kids than in adults?
Should be higher, right?
It's lower in kids.
Lower, yeah.
It's lower? I thought everything was higher in kids.
Heart rate and respiration, but blood pressure is lower.
Okay.
Yeah. So a normal blood pressure for an adult would be what?
120 over 80, right?
Yeah, 120 over 80. So a normal blood pressure for like a 6-month-old could be like 80 over 40.
That'll be the same thing for like a geriatric patient, right?
Geriatrics, they might be a little bit lower, but 80 over 40 would be really low for a geriatric patient, but that would be normal for a baby.
So it's normal for a baby. Let me write that down. 80 over 40. Okay, thank you.
And and I can send you, I mean, it varies as they get older, it approaches adult levels. I can send you guys a vital sign by age chart that has the blood pressure on there also, but that's like a ballpark. 80 over 40 for a baby is pretty normal.
If you don't mind, I appreciate that if you can.
That'll be good.
Yeah, absolutely.
Thank you.
Thank you.
So generally speaking, when you're taking the blood pressure, there's different size cuffs. So the cuff should be 2/3 of the upper arm. So you're kind of looking at the width of the cuff. So you're thinking of the arm from the shoulder to the elbow. The cuff should cover 2/3 of the arm. You're almost always going to have a blood pressure machine in the hospital, but you should always know how to do it. But usually you're going to be taking it with the machine. And it's the same thing. If the baby's screaming and crying, that could make their blood pressure higher unnecessarily. So kids frequently come in with fevers, especially when they have an infection. So when they have a fever, the inflammatory response triggers prostaglandin infection and production, and that causes their temperature to go up. So the antipyretics like Tylenol, those inhibit prostaglandin. So that's how the medication works. So, you know, there's a very specific pathway that the medications are targeting when they have a fever. And it's important to remember when they have a fever, their heart rate and their respiratory go up. So they have an increased metabolic demand. They're burning more calories when they have a fever. And that is different than something called hyperthermia. So what do you think hyperthermia is?
Isn't that when you're like
Overheated.
really cold or something?
That's hypothermia. So the hyper is high and hypo is low. So hypothermia is cold, but hyperthermia,
It's overheating.
it's
overheating.
Yeah.
Okay.
So
And
like
this is
high temperatures?
really, really high temperatures, and it's not related to an infection, and it's not related to prostaglandin infection. So it's usually kids that have something wrong with their brain. It's called a centrally mediated fever. So like you have maybe a seizure disorder or something, you know, hydrocephalus or something, and your brain isn't working normally, and then it's a centrally mediated fever. And then I saw that Makeda raised her hand.
Yeah, you answered it. Microsoft.
Okay. So so in this situation, when it's not a prostaglandin related fever, then the antipyretics aren't going to work the same way. So then the treatment involves vigorous cooling measures. So I don't know, for those of you that have been in the hospital, have you ever seen any cooling measures, or what do you think the cooling measures might be?
Cold
Ice
saline,
packs.
right? Ice packs.
Yeah. And they also have what they call cooling blankets. So
Yes, they do.
they're like blankets that you hook up to cold water, and then you take their clothes off, and there's a lot of surface area on your back. So then they lie on the cold blanket, and that helps bring their temperature down. So there's various ways that we can measure the temperature. Oral axillary is under the armpit. Temporal artery is that one that scans your forehead, and then tympanic. And then the core is in the rectal. So that's accurate. Like it gives you a good reading, but we almost never do it because it can, you can tear the mucosal lining of the anus. And then the tympanic, is this inaccurate? Do you guys think that the tympanic is a good way to check the temperature of a kid?
No.
Not if you have poor technique. If you have poor technique, it won't work.
It has a lot to do with the technique. So the tympanic membrane and the hypothalamus share circulation. So if you get a good scan of the tympanic membrane, it's accurate. But they're kind of flat and wide, and they have to fit in the ear canal. So if you have like a small kid, or if you're not getting the probe towards the tympanic membrane, you'll get an inaccurate result. But if you have good technique, it can provide you with a good reading. Do you guys?
So do you recommend it?
Yeah, like I said, you do have to make sure that you get it in the ear canal in the right way, so that it's snug in there and aiming towards the tympanic membrane. But that's what we primarily used in the hospital where I work. I don't know, do any of you work in pediatrics? Do you guys have those? They worked. We used them, and I do think that they are they're good.
Do you think, sorry, do you think the oral and the tympanic, like, I know in our peds lab, it said because it's like the same circulation, you get kind of like the same number.
Yeah. So the oral is good, but the thing is, it's hard sometimes to get the kids to keep that. It doesn't register as quickly. The tympanic is very, very quick.
Don't you use under the underarm for pediatrics?
So in the pediatric hospital where I worked, we would use under the arm if they were too small for the tympanic, if they were a baby. But as soon as we could get that probe in their ear, we would use the tympanic over the arm. A lot of times at home, people do the underarm, which is fine, but it takes a little bit longer to register the reading. So it takes more time. And that's the same thing with the oral. The oral can give you a good reading, but their mouth has to be closed. They kind of have to keep it under their tongue. It's not always feasible to get the kids to leave the thermometer in the right place.
And as far as technique is concerned, is it pinna up for babies and pinna back for children? when you're
in terms
pulling.
of for the ear, for the tympanic?
Yeah.
Oh, could you say that again? For pinna up for babies, and then
you pull the pinna up for babies and you pull it back for children.
Yeah. The main thing is that you want to make sure that I'm like imagining, you want to make sure that you get the
opening,
the opening wide, open so that you can get it in there. You'll see though, when it doesn't fit, like if you have a hard time putting it in and all, the baby's too small. So I'm sure that you guys talk about pain in the adult world. So we do in pediatrics too. So what are some pain scales that you guys have heard of? How do you measure pain in pediatrics?
With the faces.
The faces is one. So tell me about the faces.
Well, the different levels of pain has different face like expression on it.
So
they ask
and
them
who chooses? Yeah, they choose, right? They point to the face that represents their pain. And the faces is good because it can come with like different ethnicities. They can look at a face that looks like their face. And then what's another one that we use in pediatrics?
Isn't it FLAC? FLACC.
Very good. Yeah. So FLACC, it's faces, legs, activity, cry, and consolability. So there's 5, and it's scored 0 to 2 for each of the 5 elements with a maximum score of 10. So the FLAC scale converts it to like a 0 to 10 scale that you're probably more familiar with if you've worked in an adult setting. And then you would assign them like a FLAC scale of 5 on their pain scale and give them a pain medication appropriate for that pain level. And almost always when you're working, the pain scales will be built into your medical record system, so you'll be able to look at the scale when you're assessing. Okay, so we talked about all the things that you look at. We're still doing height, weight, and head circumference in pediatrics on every encounter with a healthcare provider. Head circumference is only until age 2. We normally do weight in kilos. But a lot of times parents know their child's weight in pounds. So how do you convert pounds to kilos?
Divided by 2.2.
Okay. So I'm just going to say you really, really need to remember this because all of your dosage calculations on your first test, they're going to give you the weight in pounds. I don't know. I haven't seen it, but usually they give you the weight in pounds. You have to put it in kilos and then answer the question from there. So remember that. And then height. So when kids can't stand up straight, how do we get their height?
We do length.
But you lay them down.
Lay them down and you get their length. Very good. And head circumference is also with a tape measure, slightly above the eyebrows, above their ears, all the way around. So collecting specimens. So can the CNA get a sterile urine sample for you and send it to the lab?
No.
No. Okay. Why not?
Because it's out of their scope of practice.
Yeah. So anything sterile has to be a license. So what sorts of things as a nurse are you going to be looking at and doing when you get lab specimens?
The color, the odor.
The
how much.
Yeah, very good. And then when you actually have it, you're gonna look at the physician order. Make sure that you have the correct tubes, the correct vial, whatever it has to go in. Make sure that everything's filled out correctly. Can the CNA help you label the tubes, et cetera, and get the requisition form ready?
Yeah.
They can do all that. Yep.
Jeez. What's going on? I didn't know that.
So there's a bunch of different types of specimens: urine, stool, blood, cerebral spinal fluid. How do we get cerebral spinal fluid?
You have to do it from their back, right?
Spinal tap.
Yeah, a spinal tap or a lumbar puncture. And do you know the position that you're in? Who has had a lumbar puncture before? How do they get that needle in your back?
They have you
forward in a
They have you bent over, don't they? You bent over a chair if you can.
Yeah, there's a couple of different ways. So those of you, it's going to be similar, when if you have a baby and you have an epidural, they have you kind of roll over. Usually for kids, they have them lay on their side they bend their knees and they bring their head towards their knees. So they kind of make a C shape of their spine in their bed. And then they put the needle in their spinal column. And after you have a lumbar puncture, what position should you be in after, when you come back from the procedure?
Other side.
On your side?
You actually lay on your back.
On your back.
You lay flat on your back.
Why is that?
Headaches, or spinal
It
headaches.
kind of helps prevent you from getting a headache. It kind of seals up the area where they put the needle.
Okay.
So in terms of kids and medications, do you think they're a higher risk or lower risk of toxicity?
Higher risk.
Higher risk. And why is that?
Because somebody else is
They
doing
don't metabolize drugs the same as we do.
Okay. And what specifically is different about their body?
They're smaller.
Yeah, so they're smaller and their livers are not fully mature. So most medications are metabolized by their liver and they're excreted by their kidneys. So kids, generally speaking, don't have mature livers or kidneys. And they also might have a faster transit time through their GI tract, so it can alter their medication absorption. So they are higher risk for toxicity. So there's different ways that we give medications. So, oral medications are going to be absorbed through the GI tract. There's topical medications like ointments, and then parental medications. What does it mean by parental? What does parental mean? IV. Very good. And if you have a kid that has an IV, like a continuous IV infusion, how often do you have to check their IV?
15, 20, 30.
Yeah, at least every hour. So you should be looking at that IV site at least every hour. So this is what we talked about. Most medications are metabolized by the liver, and in kids, they are metabolized more slowly because the liver and enzymes do not function at a mature level. So that makes them at a higher risk for toxicity. And then also, after they're metabolized, the metabolites are excreted through their kidneys. And if you have immature kidneys, then you're going to excrete less of the medication, which is the second point that makes kids more prone to medication toxicity. So, and then those are the two main reasons. The stomach empties a little bit slower, but the rest of the intestine is pretty rapid, and then the liver function is unpredictable. So generally speaking, it's slowly. So the two main reasons that I want you to remember are the immature kidney and the immature liver. So you should always be, after you give a medication, especially if it's a new medication, for monitoring after they take it, and making sure you always should be checking the dose. A lot of times in adults, they'll just be like, 500 milligrams every 6 hours, and they don't do it by kilogram. But in kids, you're always going to be calculating the milligrams per kilograms for every dose. So I think you guys know a lot of this. I think a lot of you are already parents. So, making sure the parent knows how to take the medication or give it to their child, where it should be stored. We talked about administering it if it's oral, getting a little oral syringe and putting the drops in the side of their mouth, offering something sweet or nice to taste afterwards. Don't tell them it tastes like candy, but you can get flavoring from the pharmacy. A lot of times they can make it taste better. So how do you guys, can someone explain to me what the process would be for giving like eye drops? How would you put eye drops in a kid's eye?
Tie them down.
you might have to restrain them.
You have to fight them.
I thought you're supposed to put the eye drops in the corner of the eyelid.
And then it can kind of roll down.
And then it rolls into the eye where you won't have to fight them as much.
And how about eardrops?
Eardrops, depending on the age, I think it's 3 and under, you pull the ear down. And if it's like 3 and above, you pull the ear up.
Okay. And can they move their head right away, or do they kind of have to sit for a few seconds?
Gotta sit. Let it go into the ear canal.
Okay, very good. And then rectal, we don't use rectal very often. Sometimes parents are sent home if their kid has a seizure disorder. They might go home with rectal Diastat, which is Valium. And sometimes they might have rectal Tylenol at home. Those are the two most common. For the same reason with the mucosal tearing, we don't use it as often, but you can give medications in the rectum. And then sub-Q and intermuscular. You'll be doing a lot of intermuscular for immunizations in the clinic. So these are, we talked about parental, you guys knew, that's the IV, and these are central here. These are these examples of different central catheters. So you should know when you give medications, you know, the maximum volume that you can do for a single injection. So for an infant, it's just 0.5 milliliter. So if they're getting multiple vaccines, they'll have to have multiple syringes that have 0.5 ml in it. Once they're, you know, walking around, they can get 1 milliliter. And where do you need to remember to, so the, where do you normally give immunizations in babies? What muscle?
In the thigh.
Deltoid.
So the deltoid is going to be older kids, but a baby, it's the thigh, and that's going to be your vastus lateralis.
Okay.
So when you're giving medications IV, then they're going to go directly into the bloodstream. So they get, you know, you don't have to go through the liver to get metabolized. They enter the bloodstream directly. So they can cause phlebitis. Can someone tell me what phlebitis is?
It's like an inflammation at the site of the injection.
And what do you do? Like if there's phlebitis versus infiltration, like how do you assess the IV?
Wouldn't you stop the infusion?
You're going to look at it and check
if it's hot or cold.
Cold or hot.
Cold is infiltration, hot is
phlebitis. Okay. And what sorts of techniques, what do you do if there's something wrong with the IV?
Remove it.
You would stop the IV and then remove it.
Okay. And what type of, like if it's in the hand, are you going to put the hand above their head or below their head?
Hello?
You're going to elevate it, and you can give them like a compress or something to help it feel better. Okay. So we talked about this. So if they're on IV fluids, at least hourly, you need to be looking at the IV, and there's a bag, and then there's a burette. So you want to make sure that it's free flowing. There's not any air in the line, and you want to be paying if there's pain or redness or swelling. Talked about that would be phlebitis, and then it could also leak if there's any moisture around that site. So there's certain things that, you know, kids, obviously they don't have the same reasoning and logic skills. So you have to, you know, kind of prepare them that they're going to get the IV. There's medication like you can put like a topical lidocaine on so they don't feel the needle pinch as much. We would take the kids to what's called a treatment room. So their room was like a safe place where painful things didn't happen. And then we would take them outside of their room to the treatment room for like the IV, and then they could get a toy from the treasure chest when they were done. So there's certain things that you can do with kids to kind of prepare them and make the IV less traumatic. And then protection, you know, you put something over the IV so they can't just knock it out. And you try really hard. If they really like to play video games, maybe put the IV in their upper arm so that they can still use their hands. So you think about what they're going to be doing and try to make their IV as comfortable as possible for them. So this is true in pediatrics and in all things nursing. The 6 rights of medication, right patient, right drug, right dose, right time, right route, and that you document it. So I would just be aware of this. I'm sure this is not new information for you, but we talk about the same sort of medication safety protocols in pediatrics. So have any of you guys heard of body surface area? Or used or calculated body surface area? So the main thing you need to know, as far as I know, all of the tests have changed from last quarter, so I haven't seen all the test questions, but you need to know that the calculating medications by body surface area is the most accurate way to dose medications. It's not used very often at all. It's a lot more cumbersome. So as far as I know, you will never be tested on calculating body surface area, but you need to recognize that it's the most accurate way to give a medication. Almost always you're going to do milligrams per kilogram. So you definitely need to know how to do this. Okay. Have you guys been taught what they call dimensional analysis for medication calculations?
Yes, and I cannot stand it.
Oh, you cannot stand it. Okay. This is my preferred method. So, but I've had students ask me, well, if I don't do it that way, well, you still get credit. So I don't look at how you solve the answer. But you do need to know how to do it. So if someone has any questions about dosage calculations, I strongly encourage you to make some time to work with me or one of the teachers on your campus, because there's going to be 10 points on every exam. So, you know, if you need a 78, and you have like an 85 and you miss all of your medication questions, that's going to drop you to a 75. It's so important that you know how to do it. It's going to be a full letter grade on every exam if you can't. So
is that the only formula we can use for those type of math problems?
No, you can. So, well, let's do one. So you said you hate it. Is there another way that you like, or do you just not know how to do it?
I prefer
I have a very complicated way of doing things.
Okay.
I can't really describe how I do it. I just kind of know. What's the it's a formula where it's called you set it up ratio proportion. That's how I do it.
Yeah. So so like if you're told that the kid needs 300 milligrams and you have 500 milligrams and 5 mLs, how would you set that up?
So I would put 300 milligrams over X equals, you said 500 milligrams? 500 milligrams over milliliters.
500 milligrams of the 5 milliliters. That's fine. That is actually, yeah, that's fine. That works. That's how I prefer to do it too.
Okay.
It doesn't matter. I don't care what your system is, as long as you have a system and you know how to do it. And if you don't have a system, then I want you to make an appointment with me so we can help you out. And I don't look at your work on your exam. You just, it's just, and it's not, the math questions are not multiple choice. You write in the answer.
Oh my goodness. It's just dimensional analysis. I feel like it's just a lot to do to get the answer, because you have to go through so many steps, and then you have to know where to put what, and it's a lot.
Okay. Yeah. So like I said, I understand. I set them up the same way that you do, where it's what I have 500 milligrams and 5 mLs, and what I want is 300. So it's 300 milligrams over X. And then I cross multiply and I solve for X. And if anyone has any questions about that, I can go over it in more detail in a tutoring session. But all I'm saying is that on the exam, you're going to work out the problem on your own and just enter the number on the exam. That's the right answer. So if you get asked a question like how many milliliters and the answer is 15, the only thing that you're going to do is write 15. You're going to solve it on your scratch paper.
So Ms. Brunel, the only, so basically what we need to know for the exam as far as math is dimensional analysis.
Okay. Yeah, I mean, you need to know something. Here, I'll give you an example. So go ahead and write this down. So your patient weighs 30 pounds. And your order is 15 milligrams per kilo every 6 hours. And what you have available is 250 milligrams in 5 mLs. How many milliliters per dose?
Okay.
And I'll give you a few minutes.
Can you say the first part again?
Sure. Your patient is, so your patient is 30 pounds and the dose is 15 milligrams per kilo. And then I totally forgot what I told you guys. So, and how many milligrams per milliliter did I tell you it was?
You said it's your patient is 30 pounds and it's 15 milligrams per kilo every 6 hours.
Okay.
And that's 250 milligrams. Your order is 250 milligrams per 5 milliliters.
Per 5 mLs. And you need to know how many milliliters per dose. Okay.
Do you want us to round? Because somebody told me that it wasn't like safe to round kids' medications.
Okay, so let's.
Yeah, I was told that too.
So yeah, let's talk about. So if it's and they'll tell you on the exam. So for example, if it's you can do you look at like the whole number and then it'll be comma or period, and then if it's above 5 you'll round up, and if it's below point, so like here 13.5. Oops.
You would round that up to 14, right?
Yeah, 0.5 would be 14, and then 13.2 would be 13.
Okay.
Excuse me, Professor. Are you gonna send us like a practice math question for the exam or no?
I certainly can if you would like one.
Yes, please.
Okay. Okay, has anyone finished it?
I did,
have, but I think
I got it
wrong.
right.
Okay, tell me what you got.
I got 5.
Oh, you're close. Who got something else?
I got 4.08 or 4.09.
4.2.
4.2 if you rounded to 14. Yeah.
Yeah, I got 4.2.
I got 4.
Okay, but
I rounded mine to 14 and I got 5.
Okay, so 14 and then 14 times 15 is 14 times, because it's 15 milligrams per kilo is your dose.
Mm-hmm.
So 14 times 15, sorry.
So you're saying we have to round the weight up?
Yeah, I will tell you that the weight on the exam will always be a whole number, so you won't have to worry about that. But in this case, we did. It was, we rounded the weight to 14 count or kilos.
So you
usually, I thought you
rounded weight before.
I thought you're only supposed to round the weight to like 1 decimal place. That's how I was taught. Like you only round the weight to 1 decimal place.
Like we've never rounded the weight before.
Okay. Yeah. Well, then let's because I know on the exam the weight will always be a whole number. You won't have to worry about it. So let's change this. Let's just say the weight is 14 kilos.
Okay.
And then go ahead and tell me what you think the answer is for how many milliliters per dose.
It would be 4.2.
Uh-huh. Did anyone else get a different answer?
I got that too.
You got that too?
So what I just noticed that I was doing wrong, because I always get like the children answers wrong, but you have to, I multiply the weight times the number that's available. Like the 14, I multiplied it by the 15. I normally don't do that.
Oh, okay. So this is what's available is the 250 milligrams and 5 mLs, but the dose is the 15. So you always have to get the dose. Yeah, every time you're going to have to do that.
Okay.
Okay. So what if it's 50 milligrams per kilo every 6? How many milligrams are they getting every 6 hours? What's 14 times 15?
210.
And so that 100%, you have to do that for every question.
Okay, thank you. I didn't know that.
Okay, so then it's 210 milligrams every 6 hours, and then you have 250 milligrams in 5 mLs. And there's, you know, I do the 210 over X equals 250 over 5 is the way that I think is the easiest way. But I think you guys have done, like, someone told me a way that you were taught, like, does someone know a different way to set it up that's like quantity?
Once I get my once I do my weight and times my the 15 grams, I put my I do dimensional analysis then. So I put my I put that 210 at the top over 1, and then I do the 5 milliliters over 250.
Okay.
She's such an overachiever.
Okay. And then it says it's every 6 hours. So how many milligrams would this person get in 24 hours per day?
840.
And how did you get that? It was 210 times what?
So times 4, because
every 6 hours.
6 and 24 is 4.
Okay. So all of those are the types of things that you're going to need to know. Sometimes they'll tell you that it's given every 6 hours, and they'll ask you how many milliliters per day. And then you're going to have to know how to get it per day. And sometimes they'll ask per dose. So pay attention to those little details. Okay. I'm glad someone asked. Yeah, ask me.
I'm sorry. Why are we multiplying 210 by 4 instead of 4.2 by 4?
Oh, because I asked how many milligrams per day. So if you were asked for how many milliliters, it would be the 4.2.
I see. Okay. Thank you.
Yeah. Okay.
Thank you for that.
Yeah. So I think that this was on a previous slide where we talked about, you know, the things they consider when you're placing an IV in a kid, making sure that, you know, you're thinking about their developmental level, preparing them for it, that they can use their hand if at all possible, if they're using their hand. So, you know,
I gotta go and,
I
got a doctor's appointment at 11 o'clock.
Oh, someone's chatting. Hold on. So the, you know, you always need to be thinking about drug interactions. Sometimes, you know, like certain antibiotics make you more photosensitive, and there's certain interactions. So, and I know a couple people have got frustrated with me about this. So iron supplements and egg yolks. So egg yolks decrease the absorption of iron, but egg whites do not. So if you're given a question about iron absorption in eggs, if it's egg yolks, they decrease the absorption. But if it's eggs in general, not necessarily. What sort of food do you think does consistently decrease the absorption of iron? Do you guys know?
Citrus.
Very
Heard a couple things. So vitamin C, like orange juice, increases, but bran decreases it. So bran decreases iron absorption, vitamin C increases it, and egg yolks decreases also. Okay. When kids are sick, sometimes they need a feeding tube. So when they're getting fed with a tube, we call that gavage feeding. So it can either be a gastrostomy tube directly in their stomach, or it can be an NG tube. So you should be paying attention. Has everyone seen a G tube before? Had a patient with a G tube. So you should be paying attention to what's coming out. If there's a change, if it becomes like a green brown, sometimes the tube can flip into the duodenum or the small intestine, and then you'll get a change in their drainage. So you need to pay attention to that. And what do you think for when you feed somebody through a tube, what position should they be in after they eat to help the formula move down?
High collar.
Am I following?
Yeah, so they can be sitting up. If they're not, they should not be flat for sure, because then they could aspirate, but sitting up and on their right side a little bit. If they're on their right side a little bit, that gives them extra room for their stomach. So sometimes putting them on their right side, especially if they haven't been tolerating their food, will help them help it move down and help them tolerate their feed. So sometimes you will still be giving enemas in pediatrics, depending on what's going on with them. You're going to use isotonic solutions. You're not going to use tap water. So tap water is hypotonic, not isotonic. Can someone tell me the difference between isotonic and hypotonic?
So isotonic goes where you put it. It goes in the vascular space, while hypotonic goes into the cells from the vascular space.
Right. So it's going to, isotonic is going to be the same concentration, right? So there won't be a fluid shift. So something like normal saline is isotonic. And very good. Tap water is hypotonic, so it has less concentration, so that fluid is going to move into the cells. Very good. So, one of the main ways that kids can get all sorts of illnesses, but they are particularly prone to respiratory illnesses. So being able to do a really good respiratory exam is important in pediatrics. So there are certain things that you should be paying attention to. Sometimes the kid will be really restless and agitated, and you won't know why. And that could be their subtle sign of having increased worker breathing or problems with their respiratory state. Also, just getting a faster heart rate. We talked about the fact that kids in general have a faster heart rate, but if you have your baseline, like your kid came in and his heart rate was 100, and then you notice that it's getting faster and faster and faster, that could be because they're having a hard time breathing. Sometimes they'll get fatigued. This is going to be later, like the fatigue and not moving around as much, that's a later sign. And then we talk about retractions. So who can tell me what retractions are and what they look like in a kid?
The chest, hard breathing, the chest going up and down real hard.
Well, you can see like the chest, like the bones in the chest.
Oh, very good. So we call it accessory muscle use, and you'll see it, you can see it from their nose all the way down to their pelvis. So you'll see their nose flaring, nasal flaring. You'll see them pulling in around their sternum. You'll see the skin kind of sucking in, and then in between their ribs, you'll see it pulling in around their ribs. So all of that is our retractions. And they can also become really pale. And cyanosis, what does cyanosis mean?
Blue discoloration.
Yeah.
Blue in the face.
Yeah, and where are you going to see that?
The lips.
You might see it in the lips, and obviously people have different colors of skin. So sometimes you can see it in their fingertips or in their nail beds. Kind of think about where the skin is. The nail beds are paler than the rest of the skin usually, so you can kind of see it in that nail bed also. So when we have an airway obstruction, so in nursing school, are you required to have your CPR? Do you do your basic life support?
Yes.
Yeah. Okay. So for a baby and they think they swallowed something, how do you get an airway obstruction out for a baby?
You hold them.
You do the
hold them and
like the
back.
And these thrust.
Wait, it's a lot of people talking.
That.
I'm going to call on one person here. Go ahead, Makeda. Do you know?
From what I remember, you tilt the baby's head. No, that's for the CPR. You try to do a finger sweep for CPR or for airway obstruction.
Yeah, you can do a finger sweep, but if you feel like if they swallowed it, you've done that, you can't get it out. The first thing you do is back blows. So if they're a baby, do 5 back blows, you turn them over and you do 5 abdominal thrusts. And then an older kid, you're going to start with abdominal thrusts. So an example, the Heimlich maneuver. Have you heard of the Heimlich maneuver where you kind of take your hands and you go up?
Yes.
That's an abdominal thrust. You can also have them down on the ground and you put your hands together and you push up right below the diaphragm. Yeah, right here, right above the diaphragm, right where that notch is, where your rib cage is, and you push up. So you're going to try to push air up to pop the obstructed thing out. But for babies, you do 5 back blows followed by 5 abdominal thrusts, and older kids, you start with the abdominal thrusts.
I have a question.
Yes.
For the airway obstruction for babies, do you have to put them in a certain position, like tilt them slightly to the ground or something like that.
So if they're, yeah, for the baby, you know, you should have them over your arm and their head should be to the side. And then you should pound their and hit their back.
Okay. Thank you.
Yeah. And then the last thing that we're going to touch on before I have you guys think about some discussion questions is preoperative and postoperative care. So what about things like NPO time and stuff like that? How long do you normally have to be NPO before you have a surgery?
It's like 8 hours or something.
Yeah. Mm-hmm. So a kid, do they do well with not having anything to eat or drink for 8 hours, or a baby?
No.
4 to 6.
So it will still be 8. So a lot of times it's after midnight for an AM surgery. So it's more common in kids to admit them and then get them on IV fluid before surgery. And then they go from their hospital room to the surgery so they can get their IV fluid overnight. So that's why here it says infants should not be maintained NPO for longer than 46 hours. So, you know, if they are, then they need to be on the IV fluid. So it's common that they will get IV fluid before they go in. And then the postoperative and then preoperative, you need to make sure their consent is formed, their labs have been done, the parents understand the procedure, et cetera. And then postoperative, you're going to be minimizing their pain, making sure that they're recovering from anesthesia, getting them ready to go home. Most of the time, it's, you know, if it's a day surgery, they'll go to the PACU and then you'll be giving discharge from the PACU. And sometimes kids will go back up to the floor and they'll spend the night after surgery and they'll go home the next day. Have you guys dealt, for those of you that work, have you worked in pre-op and post-op before? Anyone?
I have, but not with babies or children.
Oh, okay.
I worked in an emergency room where they come for emergencies and we have to kind of put them on papoose if we have to do stitches or.
Oh, wow.
Yeah, but no, I don't think I would be able to handle that.
Oh, no. Okay, so what we're gonna do here, see here, I think there's just 24 people in class. So I'm going to pick a couple questions and then I'm going to step away and I'm going to let you guys talk about it as a group. And then I'm going to have you give me the answers that you came up with. So, so this one here, I'll go ahead and put this in the chat for you. Let's see here. Here's my chat. Okay, so this one here, it says, oops, a nurse is admitting a 3-year-old boy with a very high temperature, we'll say it's 104 degrees Fahrenheit, who is restless and crying. What safety measures should the nurse institute on admission for this child? And I want you guys to come up with 5. And I'll pick someone here. Let's see here. Daphne, do you think you can be the secretary and write down the 5 interventions or the 5 safety measures that you're going to come up with? So what I want you to do, I'm going to give you 10 minutes. I want you guys, I'm going to step away for a minute, but I'll be here. You can put something in the chat if you have a question for me. But I want you to talk as a class about 5 things that as a nurse you would do that would address this child's safety. Does everyone understand?
Yes.
Okay. And then Daphne, are you okay with being the secretary? You're just going to write down. So when we regroup, you can tell me the 5 things. If not Daphne, I can choose somebody else. I just want to let me know if you're okay doing it. Is that a yes? You can do it? Who said that?
Yesy or Yetsaira.
Okay, perfect. Thank you. So I'm going to be right here, but I'm going to take my headphones off. If you have a question, you can put it in the chat, but I want you guys to talk amongst yourselves and come up with 5 things that you would do for this patient. Okay?
All righty, guys, go ahead. I have IV fluids, medication, probably cold compresses or trying to take some stuff off, seizure precautions maybe, hospital bed railings, padded, maybe up. Parent or guardian one-on-one there just in case.
Yeah. Okay, you done. Yeah, I know. That's all.
That's it. That's it.
Yeah.
5.
Thank you, Yetzi.
Well, I said go ahead.
You finished it.
Come on.
I didn't really hear you, but yeah, that was 5.
Can you put it in the chat?
Yeah.
Thank you.
You're right. Okay. See, I have it on my paper.
You about to type all that in the chat, Yessie?
Are we supposed to be looking at all of these questions, or which question is it?
She put the question in the chat.
That's the one that she put in the chat.
Wow.
That's only 4. We need one more. But I wouldn't necessarily say the padding just because the child's 3 years old, even though they're restless, they're not really so much. That's not really gonna help him with his fever.
Right.
No, yeah, but you having a seizure that can protect him from injury, though. The pads on the bed.
Yeah, but he's not having a seizure right now. It's just the padding. It's not like a necessary thing right now to like prevent him, because if he's in a bed, he's just gonna have like the bed. Well, he's gonna have like a little crib bed for a 3-year-old.
Being febrile,
you should be also focused on bringing the fever down.
Yeah, but that's what I was thinking. I'm thinking more so about the fever, not necessarily
so like
the padding.
Measures.
Yeah, like
but when you're extremely, but I think the padding and the rails being up would still be
I feel like
a necessary precaution, because when you're febrile, you're at risk of having a seizure.
Right, and to prevent it from happening, you already got something in place to stop him from being injured. Yeah. I feel like that's a good idea to keep that there.
Mm-hmm. Right, I agree.
All right.
And maybe like
go ahead.
A glass of milk or something for him being restless or something. I don't know.
Bobby, I saw you.
I would say check the airway, because if he's restless, it could be something with his airway that's causing him to be restless. So that's why I was thinking, to add that to that instead of those paddings and stuff. Because I feel like that padding it's not like a necessity right now for that fever.
Mm-hmm.
The main focus should be the fever, so trying to get it down would be good.
And lift the bed down to like semi-fullers, not like straight down.
Right. If the temperature is high, will they be like having a seizure?
If the temperature gets too high, it can cause a seizure.
But
his temperature is like, he's a temperature like 104 right now. So like those pads are not like a intimate, like something to help him right now. Like that's a precaution that you can do later, but like an emergency, like right now, what you need to do as a nurse, I don't feel like the pads are like something that you need. You can do it later. I'm not saying it's like not a good idea, but I'm saying like right now for him, no.
Yeah. You definitely need to address.
It's not like a priority.
Prioritize.
Yeah.
Well, we already reduced the fever, so like we put medication to reduce the fever. So
sometimes it don't work though. Sometimes
it doesn't work right away.
We got cold compresses on there.
That should help.
Would y'all give him fluids? Like as far as like offering,
they got fluids on there already.
We got IV fluids on there.
Okay.
Reynolds.
All right. I hear a lot of good stuff. And I looked through everything that you put in the chat, and I agree in terms of the seizure precautions. So you're not, maybe, but definitely doing like scheduled neuro assessments. You do want to be following up on the neuro exam. So, he could have a seizure, but you could also just be going towards altered level of consciousness, changing. So I understand why the seizure precautions, but instead of seizure precautions, I would do like frequent neuro.
Dehydration.
Yeah, you're going to have to be addressing hydration, and this is going to be, some kids, when their fever is that high, they're awake and alert, and maybe they can drink some cold fluids and maybe they can't. So, either depending on their mental status and their respiratory status, maybe they can drink or maybe they're going to get IV fluids. Good job, you guys. I'm very impressed. I'm going to give you one more. This is going to be a teenager one. And it's not so much an illness. It's a parenting thing. So this one says, a parent tells you that his 15-year-old, sorry, I got to send it to you. A parent tells you that his 15-year-old daughter has suddenly entered a period of rebellion and is breaking all the household rules. Last night, she came home an hour after curfew with no explanation, and she often becomes angry and sullen when disciplined. The parents ask the nurse why his daughter's behavior has suddenly changed and what he can do to stop it. So what sort of advice would you give to this dad? And I'll give you guys another 10 minutes.
I feel like she's just in that going through puberty.
Yeah, she's
just a
teenager. You can find out what's going on during that time period.
Came home.
Like, why is she out? And also, it could be like, she could have had like an injury and could have a brain bleed because, that can cause an altered mental status too and cause erratic behavior if it's something out of her norm.
She might have a UTI.
I know in like the Erickson stages of development, like teenagers have like a hard time identifying themselves. So,
or something traumatic happened to her that she came later. Because the parent wasn't there, so you don't know if someone abused her, or because they act up when something happens to them.
Or when there's a phase where like teenagers go through like at school if they're being bullied,
peer pressure,
and then at home they turn that into like a rage where they let out at home instead of letting it out in public. Does that make sense?
Definitely.
Yeah.
Misdirected anger. Yes, that's exactly what it is.
So maybe like refer them to like a therapist or a counselor.
Yes, that'll be good.
And then you also could tell them like, get a actually talk to the child to see what's going on.
Yes.
Because communicate, because you never know until you actually sit down and talk with them.
Yeah. Gain a rapport with the teenager
gain the child's
first.
trust, because once you gain, like if the dad was to gain her trust, she'll feel more comfortable talking about whatever is going on. Like just be more like open up and talk to her.
And just see if there's
and as a nurse, like if I was in that situation, I would like with the parents' permission, I would ask if it'll be okay to speak to the child alone, because sometimes they open up when their parents not around. And then I would see like
counselor at school.
Yeah, I'll get to the bottom of it, and then I'll ask them, like, once you gain their trust, I'll ask them like, hey, do you mind if we let your parent come in, and then we can let them know what's going on, and we can like find some type of outlets and et cetera, et cetera.
Yep, what they said.
Bobby Joe. Okay, Bobby.
I second that.
Y'all are hilarious.
I third it.
I'm 4.
I said it sounds like a good deal. It sounds like a good deal of communication, and just basically figure out what everything is going on with the team.
Then to just go out.
How many are we supposed to be having? We're supposed to have 5, right?
Yeah.
Okay. So
then to go further, maybe we could like say that maybe there's something going on between, like, I don't know, maybe like some type of abuse going on at the home, and that's why they could be rebellion. So like Davy said, just like getting them by themselves and talking to them about that too.
Also put in the thing, put them down for like a neuro check, because that could be an issue. See if like the child hit her head, something, you know, lately within the past, because that could be a brain
and drugs.
And lead exposure can lead
alcohol.
But see, I don't think lead exposure would affect an adolescent more than it'll affect a school age child. So I would say like drugs. I'll get them a drug.
But if
screening.
you in a house that has lead and it's been activated, it can affect a child more, but it can still affect the adolescents.
Or they could be being a teenager and trying to figure out who they are in life.
That's right. Yes.
Maybe they're just testing their limits.
Just the normal thing.
Yeah, Nisha. They testing how far they could go before they get dropped.
They try to see how far they can go.
And I mean,
they want to be a boy instead of a girl.
Or you know what?
But it says suddenly changed.
You think about it, a 15-year-old daughter, she probably, or 15-year-old girl, she's probably in that phase to where like she's starting to like somebody. You know how you go into that hot phase?
She feeling herself. That's what
feeling
it is.
herself.
Boom.
She feeling herself.
That's what it is. She feeling herself. You know, she like somebody. Somebody that spiked her interest, her hormones all over the place.
Yes, the boys is on her. And she got
or the girls one. I'm just saying.
I'm just saying.
Confused.
Yeah.
Even though it says a sudden change, it may not be a sudden. It may be a sudden change to the parent because they're not realizing it. But
LGBT community.
Yeah, that's why I said a neuro check, because when they said the sudden change, because my aunt, she had ended up having a brain bleed, but her like behavior like suddenly changed. Like she started acting way more different than what she normally is. Like, so that's why I felt like it was like a neuro check for a brain bleed, because if it's sudden, it could be something like a head injury that happened, like you hit your head and didn't know that you had a bleed on the brain.
So we said neuro check.
It could be just a mental disorder.
They said they got puberty, growing up with they rebellious, they got trauma event, they got refer to counseling, assessment and labs, and they got a neuro check.
Okay. Y'all don't think that it's like a mental, her trying to fit in with her peers?
That's it, David.
That identity crisis, yeah.
Y'all
can put that as well.
Just type it in, David.
Oh, we could type it. I thought somebody else was typing it. I'm sorry.
He put it in the chat. So just type it in.
Somebody did, David.
They put it in there.
Oh yeah, we also said drugs.
A little slow.
Yeah. That's another one, definitely drugs. To make them ready.
This was a good example because it's not all of it don't have to be a medical reason. It could be it could be affected environmental or personal. So I feel like this was a good example.
Or it could be like a normal finding for her age range, to be like she going through, like she doesn't really know herself.
Yeah, for her age.
Or you know what else too? She could just be acting out to get their parents' attention. You know how after a while your kids feel like, oh, they don't see me anymore, or you know, they don't spend enough time with me. She's probably just acting out to get some type of
attention.
Yeah.
What I said.
Sloppy Joe.
What did she say? I can't hear you repeat. What she say?
She said that's what she said.
She said what she said.
Okay.
I think that's 5. I think that's more than 5, y'all.
Yeah.
Yeah, that's more than 5. David, why is she drinking Red Bull this early?
Don't judge you. Look, tell her don't judge you. I'm over here.
It's too early.
Right here.
I'm a nursing student.
Oh gosh.
I'm a nursing student. I couldn't get coffee.
Davey.
I'm struggling.
I got it.
Okay. I'm gonna wear this same bun all week.
Cause you wide open.
I'm going to get my hair done after this. I got a 1 o'clock appointment.
Listen, I saw
pressure.
You was going through that Michael Jackson Afro craze, and I won't say nothing because it's early.
Girl, it's early.
Keep it related.
I had just washed my hair. My hair was still wet when I got on this class.
You looking like a rebellious teen with your hair like that. But I love you.
You cute.
I love you.
Oh, hush, David. David, did you go? Did you you know you got to go to another class for your community, because you know we got that class.
Don't talk my business. Don't talk.
I'm just saying, because Tiffany came to my class, so I was like, dang, I should have wrote David and see was David.
You should have, but you didn't. Where was your antennas?
Because I was in class.
So David gets to go to that with her red bull because she is stressing.
Okay.
Okay.
Y'all supposed to be ready.
So it sounds like you guys are done.
Yeah,
Very good. So I see. I'm looking through your comments here. You think that she's in puberty, obviously. So I see a lot about like this is normal behavior, fitting in with peers, sort of crisis. Somebody mentioned counseling. Maybe. What do you think you might be able to do before you do counseling? Like what sorts of parenting advice could you give this dad?
Talk to them, girl.
Yeah. How do you talk to a teen?
You
feed them
music
first.
and dance with her.
First. I love it.
You build trust, use some of the words that they use.
Yeah, very good.
And you can put them out by themselves.
Take her to the movies and talk with her.
Like a neutral event.
Conversations will go a long way if you give them a bag of Takis.
Well, there you go. So
Red Bull.
You try to establish a rapport. You have it. So like you're going to try to sit down and talk to her in a calm way. You're not going to like be really angry when you talk to her, right? Because if the dad's coming into the conversation really angry, how is she going to respond? Angry. So she's going to kind of
who you talking to?
So you're going to try to have a calm conversation, and maybe like at this age, like a teenager, can she understand why there are rules? Like, does she have the ability to understand why she's being disciplined?
Yes, she has the ability, but she ain't gonna do it.
Yeah.
Well, okay.
Good common sense.
Okay. All right. I feel like you guys understood that. So that's the main thing, is recognize that it's normal, reassure the dad that it's normal behavior, but he should still be setting boundaries and having limits, right? Like he can, and still like, what sorts of things might you punish a teenager? Like she's consistently coming home late after her curfew.
If she come home after that street light come on, it's a problem.
Okay, so how are you going to respond as a parent though? Like, what?
Give me your phone.
Start taking away their phone.
You could take the phone, the TV, games, stuff that they really like.
Her privileges.
Okay.
Give me the iPad.
My mom, my mom used to take my clothes. She used to only give us like 7 outfits, and she was like, "You gonna wear this for 2 weeks?"
Murata, don't say that out loud. They gonna go get your mama, girl. Hey.
All right, guys. So good job with the discussion questions. I'm gonna start sharing my screen again. We're gonna do a Kahoot here, and then you guys are gonna take a quiz. But I'll give you a break in between the Kahoot and your quiz.
I'm scared to play the Kahoot because this caffeine running. I'm gonna press the wrong button and be mad. Y'all know I get mad when I lose
Kahoot for that. Let me grab my phone.
Okay.
It's about to go down.
Alrighty. Let's see here. I'll go ahead and you guys go ahead and grab your phone, and we'll get started here in just a second. All right.
Wayne, I like your little cat. He got a little swag to him.
Thank you.
Okay, I'm going to go ahead and hit start.
Is some of this going to be for the quiz?
Yes.
Okay.
What is the best location for the nurse to use when assessing the pulse of a 12-month-old infant? The brachial, apical, femoral, or radial?
Boy, y'all is not playing. Y'all answering fast.
Very good. So that's what we talked about. When it's under 5, you should really listen at the heart, at that apical area, to get the heart rate, the pulse. So what is the definition of a latchkey child? A child who attends daycare after school, a child who lives in a homeless shelter, a child who takes the school bus, or a child who is home alone after school without adult supervision. Very good. So latchkey is a child that goes to school, goes home after school and doesn't have any adult supervision. So what sorts of things do you teach parents if this is the situation they're in, that their 10-year-old is home alone for a few hours? What sorts of things do you teach the parents that the child should do to stay safe?
They shouldn't
open my door.
Okay.
For nobody.
Yeah.
Don't get in a car with like strange people that offer you a ride. Don't walk through dark alleys.
Yeah.
Don't let anybody know you're home alone.
Oh.
Mm-hmm. And don't play with fire. Don't even touch my microwave. Go get you some fruit snacks and sit down.
Okay. So yeah, in terms of certainly don't want it like common knowledge. Maybe a trusted neighbor might know that the kid's home alone, something that you trust that could maybe check on the kid. And should they have friends over?
No.
Okay. Very good.
And like if the door is open, don't go in. You shouldn't go in yet.
Yeah. So a 9-year-old needs a lumbar puncture. What position will the nurse explain the child assume for this procedure? On your back with your legs extended straight out, on your side with your knees bent and your head close to your knees, on your stomach with your head turned to the side, or on your side keeping the legs bent and head arched back? So good. Yeah, it's on your side and you kind of make a C. You bend your knees and you move your head towards your knees. Very good.
I was thinking more of a infant with that whenever you did that.
Oh, yeah. Yeah, the infant, you can position them differently. So an infant's dry diaper weighs 2.5 grams and the wet diaper is 47 grams. How would you record the infant's urine output? 44.5, 40, 47, or 42? So several of you got this right. So for those of you that got it right, what did you do to solve that problem?
So what you do is you just subtract the wet diaper from the dry diaper to understand how much it actually secreted the diaper, if that makes sense.
Yeah. So 1 gram is equal to 1 milliliter. So if the wet diaper is 47 grams and the dry diaper is 2.5, you subtract the 2.5 from the 47 to get 44.5, and that's 44.5 milliliters. So, you know, for a baby, they can't pee in a cup or in the hat or that other stuff that adults do. So you just subtract their dry weight from their wet weight, and 1 gram equals 1 milliliter. All right, so select all that apply. Which medication should be checked with a second licensed nurse prior to administration? Vancomycin, digoxin, IV heparin, insulin, and IV morphine.
This one was hard.
I pressed submit way too early because I know it's
Okay, so all of them except vancomycin. So vancomycin does not require a co-signature, but your IV narcotics, all of them do. Insulin, IV heparin, any anticoagulant, and digoxin.
Can I challenge that answer? Because Vanco is an antibiotic. It's a high alert.
So this is another select all that apply. A 3-year-old patient is admitted to the pediatric unit with a fever of 103. Which actions will the nurse implement? Assess level of consciousness, assess skin turgor, administer acetaminophen as ordered, restrict fluids, and assess rectal temperature every 4 hours. All righty. So assess level of consciousness. You guys talked about seizure precautions, but assess level of consciousness for sure. Skin turgor, that's going to look at hydration status. And then administer Tylenol. Restrict fluids, you're not going to do, obviously, right? And then why is the assess rectal temperature every 4 hours? Why is that one not correct?
I didn't pay attention that he said
time frame.
Ah, right. Very good. Because it's rectal, right? And maybe you might check more often than every 4 hours, but the main thing here is this is a rectal temperature. So you're not going to be checking a rectal temperature every 4 hours. Very good. So what strategy might the nurse use when administering an oral medication to a young child who is reluctant? Tell the child the medicine it's candy, mix the medication with chocolate milk, offer the child fruit juice after the medication is swallowed, or give the medication quickly if the child is crying.
Oh, that's the wrong answer. Shoot.
Many of you got it right. So you're going to give it, try to bribe them. This is, a child that's old enough to kind of talk to you. You can offer a little bit of juice, just take this couple drops and then you can have your fruit juice. So here's a practice one for you. So you have an oral suspension of 400 milligrams PO daily. That's your dose. And you have available 125 milligrams in 5 mLs. How many milliliters per dose are you going to give this patient? All right, so several of you, okay, maybe you didn't have enough time. Those of you that answered got the right answer, and it was 16. So if I will post in the announcement a couple of questions for you to practice that have that worked out for you. I have a couple of math in here because I feel so bad when students miss their math questions because it's a full letter grade on your test. So I just focus on that because I want you guys to be able to do it. So your order is 150,000 units intramuscularly twice a day, and you have 600,000 units in 5 mLs. How many milliliters are you going to give per dose?
I can't do math problems super fast. So.
Okay. Okay. That's fine. Who told me that? I'm sorry, I didn't see who was speaking.
Chanel.
Chanel. Okay, Chanel, that's fine. I think you'll have enough time on your test, but I wanted to put this in the Kahoot before your test so you guys were aware that you're going to have them and that you would be paying attention and ask me questions if you don't know how to set them up. If it takes you a little bit more time, that's fine. I think you'll have plenty of time on the test. And this is the last one that's in this Kahoot. I just wanted to kind of get your brain recognizing that you're going to need to know how to do this. Okay. All right. Good job. Oh, I'm sorry. This is the last one. So Lovenox 50 milligrams sub-Q every 12 hours, and you have 100 milligrams and 5 mLs. How many milliliters per dose? So most of you, yes, most of you recognize this one. You should be able to kind of look at. So 50 milligrams is half of 100. So if you have 100 milligrams and 5 mLs, 50 milligrams is 2.5. That one should be a little bit more like logical. You can kind of look and be like, oh yeah, that makes sense to me because half of 100 is 50. A parent says, I'm not sure how to give this medication to my infant. What is the best response from the nurse? Place the medication in a nipple and have the infant suck the nipple. Give the medication with a dropper into the back of the infant's tongue. Use an oral syringe to place the medicine on the side of the mouth, or pour the medicine into a small cup, allowing the infant to drink it. Yeah, so very good. Kind of, you want it in the side of their mouth. If you put it right in the back, they could choke. And you don't want to mix it with anything because then it's hard to know if they took all their medicine. So a 6-year-old takes iron supplements. The nurse advises that which food decreases the absorption of iron? Red meat, acidic fruit juices, bran, or green leafy vegetables?
I'm not drinking Red Bull ever again. I hit that too fast.
Very good. So the other one that I thought might be some other people, the ones that acidic fruit juices like orange juice. So vitamin C actually increases, doesn't decrease. So bran decreases. So very good.
In the book, they have milk there. I don't know.
Yeah, milk also does decrease. Very good. That's another one that decreases absorption of iron. You're right. The incoming night nurse gets report on his patients from the day nurse. Which finding requires immediate attention? An adolescent with a respiratory rate of 28, a school-age child with a widening pulse pressure, an infant with a pulse rate of 100, or a toddler with an axillary temperature of 99. All right, so several of you. So the respiratory rate of 28, that's fast for an adolescent, but the widened pulse pressure, this is something that you should sort of recognize as could be an emergency. So you can see like a widened pulse pressure when they're having cardiovascular problems, if they're having increased intracranial pressure. So this is something that if you see the number between the systolic and the diastolic getting bigger, this is something that you should kind of file in your brain as something that could be an emergency.
Is that the MAP number that they're talking about?
Yeah, absolutely. Yes.
Whenever you're saying MAP, are you talking about like the QTRS?
Okay, we'll answer that in just a second. So a 15-year-old returns to the unit following a lumbar puncture. What initial position should the child be in? Supine, prone, lying on the left side, or semi-flowers? Okay, So that was supine. So that's after they put the needle in the back, they should lay right on their spine to kind of seal that area up and help prevent them from getting a headache.
Is prone laying like with your back facing up?
Yeah. Yeah. Yep. So I remember supine is on your spine.
Okay.
And then prone is mouth, you're down. Yeah. So in terms of the other question, so the MAP is the mean arterial pressure. And and I actually said it incorrectly. So that's your mean arterial pressure. So the widening pulse pressure is different from the MAP. The widening pulse pressure is just a difference between the systolic and the diastolic. So, so if your blood pressure was 120 over 60, and then it goes to 120 over 40, then you have a widened pulse pressure because there's a bigger difference because your diastolic dropped. So then there's a bigger difference between your systolic and diastolic, and that's a problem. And then someone else asked if the MAP was a QRST. So that's all on your cardiac strip. The P wave is your, and we'll talk about it later, but that's like the P wave is your atrium firing, QRS is your ventricle. And then their T wave is the repolarization of the ventricle. So that's when you're talking about the QRST, you're talking about the electro charge.
Cardiogram.
Yeah. So that's different than anything that we're talking about with the blood pressure.
Okay.
Okay. Thank you for asking though. Does anyone else have any questions about that last one, about the widening pulse pressure? Okay, so this is another select all that apply. Informed consent for a minor guarantees that the parents or legal guardian understand what aspects of a procedure, the risks associated with the procedure, the purpose of the procedure, that the document must be signed in witness, that no suit can be brought for damages, or that information was given, and/or is the select all. Right, so most of you got this right. So even though they sign an informed consent, if something went wrong, they would still sue. So it's not true that signing the informed consent means that they can't bring a suit for damages. So good job. All righty. So the nurse notices her 2-month-old patient does not have an ID bracelet. What should the nurse do? Confirm the child's name from the sticker at the foot of the crib. Ask the admin office to make a new ID bracelet, confirm the identity with the charge nurse and make a new bracelet, or ask the charge nurse to make a new bracelet.
Oh crap, I hit the wrong one.
Right, so you're gonna confirm the identity with the charge nurse or with the parents or with somebody that knows the kid and then make them a new bracelet. So gentamicin eardrops are prescribed to a 4-year-old. How would the nurse position the auricle? Up and out, down and back, up and back, or down and out? So yeah, so up and back to kind of get it in there so that you can get the canal open and get the drops in there. So why is the tympanic thermometer considered more accurate than other types of thermometers? It shares circulation with the hypothalamus. The probe is blunt and wide. It takes a brief time to register, or it has the same temperature as the brain. All right, good job. Right, it shares the circulation with the hypothalamus. So which intervention is correct when the nurse is administering gastrostomy feeding by gravity? Position child on the right side after the feeding. Refill the syringe with formula after it is completely emptied. Flush the tube with 2 to 4 ounces of water before the feed, or discard the residual and add that volume to the next feed. So I know several of you chose the 2 to 4 ounces of water. It's okay. You should flush it with a little bit, but especially with a kid, 2 to 4 ounces of water is quite a bit of liquid. So that's why this one is not the best answer, because that could be a lot of liquid for a kid. You want to do it, you know, maybe 5 mLs to make sure the tube is working, but not, you know, 4 ounces would be 120 milliliters. That could be their whole feed. So you're not going to use that much on a kid. And then putting them on the right side kind of gives their stomach a little bit more room, and they could help the food move down. So how often should a child who has continuous intravenous infusion be assessed? Every 2 hours, every 4 hours, every 3 hours, or hourly? Yeah, hourly. Very good. Which intervention will the nurse implement when suctioning a tracheostomy? Clear the catheter with water after suctioning for reuse. Apply suction for no more than 15 seconds. Suction for 2 to 3 breaths, or establish a regular suctioning schedule. Right, so you suction for no more than 15 seconds. You don't need a regular schedule. You should really suction when they need to be suctioned. And 2 to 3 breaths is too long. They could start to feel like they're choking if you suction for that long. Yeah.
I thought you're only supposed to suction for 10 seconds. I was taught 10 seconds.
Okay, so there could be, like, I normally teach 10 to 15, so that's fine. You know, it's so certainly no more than 15, but on the 10 to 15, I mean, if you're, so this book says 15, but I do understand that sometimes they teach you 10. So I would kind of file 10 to 15 seconds in your brain.
Okay.
Okay.
Yes, ma'am.
What emergency action should be implemented for airway obstruction in an infant? Abdominal thrust until the object is expelled, 5 chest thrusts followed by 5 back blows, 6 to 10 mid-sternal thrusts, or 5 back blows followed by 5 chest thrusts. So good job. Yeah, you start with the back blows and then you flip them over and you do the abdominal thrusts. Or chest, I guess. So a 4-year-old child is asked cheerfully if an IM injection will hurt. What is the nurse's most effective response? Yes, your mom and I are going to hold you to help you be still. No, would you like to see the syringe? Yes, it will sting a little, or no, it'll be over before you know it. Yeah, so it's better to be honest with them. Tell them it's going to hurt a little bit. Don't lie to them. So the best answer is to be, yeah, it's going to sting a little bit. So where is the best site for an IM injection in a 15-month-old? The dorsal gluteal, the deltoid, the ventral gluteal, or the vastus lateralis? So it's the vastus lateralis, it's that side thigh there. Okay, last one. Dun, 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 dun. Which factor does the nurse explain affects the infant's physiological response to medications? Increased secretion of hydrochloric acid, faster metabolism in the liver, slower intestinal tract or transit, or immature kidney function? So very good. Let's see here. A couple of you chose faster metabolism in the liver. It's actually slower metabolism in the liver, not faster. So immature kidney function, and then the stomach is slower, but the intestinal tract is faster. So that's why the blue one isn't right. All right, dun dun dun. All right. Who is Nurse Tings?
That would be me.
Didn't she win last week too?
I was in third place last week.
Ah.
Go, Danny.
Very nice. Very, very good. Okay, so the only thing left for class is your quiz. Do you guys want to take a 10-minute break and come back, or do you just want to take your quiz?
We can take the quiz.
No, we can take it now.
Okay. So there's just one thing that I think is on there that we haven't talked about. So I want to talk about adolescents for just a quick second. So when you're screening for alcohol and drug use in the outpatient clinic, does anyone remember the name of the survey or the form or the survey, I guess, that you can use to kind of screen for alcohol and drug use?
The survey for drug use?
Yeah, specifically for teens.
I forgot the name of it, but I know what you're talking about.
Okay, well, I'm glad somebody does. We kind of just barely touched on it. So it's the PACE survey.
Mm-hmm.
So, and every letter in PACE stands for something that you would follow up on, like peers, alcohol. So it's the PACE survey is a survey that you would use to screen for alcohol and drug use in teens. I think we talked about everything else that's on your quiz in today's class.
You said it's called PACE?
Yeah, PACE, P-A-C-E.
Oh, okay. I'm thinking of P-A-S-T-E. Okay.
Oh, yeah. No, I'm glad you asked. So I think I logged on. Everyone needs to turn their camera back on here. I see a couple people without cameras on. So Daphne, Chidima, thank you. Let me take a look here. I think the quiz is set up. I went in, I mean, obviously I've struggled with getting the times right on the quiz, but I think everyone should have it on. So go ahead and log on. If you don't have it for some reason, let me know and I can fix it. But I think everyone's quiz is turned on.
I'm doing mine on the phone. Is that okay?
Yeah,
that's not on.
All right.
Mine's not on as well.
What's your name?
Chris Jones.
Chris Jones. All right.
And
Chris.
Pendrikia Hall.
Pendrikia Hall. Maybe you were the two that were in Betty's class, right?
Yes.
Okay. Let me take a look here. Chris Jones and Pendrikia Hall.
Can we go ahead and start?
Yeah, you can go ahead and start. I'm going to fix Chris and Pendrikia while we're talking, but the rest of you can go ahead and start. Oh, sorry. I'm still sharing my screen, so let me stop sharing so you don't see me messing with your quiz times.
I'm having some connectivity issues.
Okay, are you on your phone or what's going on?
I can't get in.
You can't get in? Okay. There we go.
No. Wait. Oh, come on. Oh, wait. I might have to go out and come back in. My computer is being really stupid right now.
Okay. Just let me know when you're back in. You can put a message in the chat, okay?
I still can't get in.
Okay, is that Pendrikia Hall?
Yes.
Okay, I haven't changed it for you yet. Just a second.
Oh, okay. Sorry.
No, you're fine.
Quick question, Professor. Once we finish the quiz, are we to leave class or you want us to wait?
No, you can leave.
Okay.
My goodness. Okay. All right, so Chris and Padrika, could you go in and try to log out and log back in and tell me if you can see it?
Okay, I'm in.
Okay, perfect.
Can we log out once we're done?
Yep, once you're done, you can go ahead and log off.
Thank you so much.
Hello, I'm done. Has mine posted? Do you see where I completed it, or you can't see it right now?
They pull through. I haven't checked right now because.
All right. Okay, I'm done though. So you have a good day.
You too.
Okay. All right.
Miss Brunel, I have a question.
Yeah. Go ahead. Yeah, go ahead.
Mind like putting me in a like a break room?
Yeah, I was trying to figure out who asked me that. I thought it was Chanel Lott, but you're Anastasia, right?
Yes, ma'am.
Okay. Yeah, that's fine, Anastasia. I'll do that for you in just a second.
Oh, them first two. I'm sorry. I think
Do you have a question, Anisha? Oh, you're muted.
Sorry. I didn't know if you got my message. I had sent you a direct message.
Hello, I'm done, but I have a question about the NCLEX questions that need to be submitted. Okay, there's just one other student on, but you can, that's fine with me. You can ask her. What's your question about the NCLEX questions?
It was, like, I know when we're selecting like developmental stages, but, and it said, I think it said infant through to adolescence. So is it just infant and adolescence, or is it like infant,
adolescent? Yeah, infant, school age, all the way, the entire age range.
Okay. So there would be like that whole section in there?
Yeah.
Okay. I was just making sure because I was like, that's not how they're set up and that's not how they're layered. So that's why I was asking.
Oh, okay.
So I know I have to select them.
Yeah.
And then I just had another thing. Are you able to send out your handouts as a PowerPoint and not as, I don't know, it's like some PPTX? Like for some reason, it's not uploading.
Oh, it isn't. Okay, I can try resaving it as a different file type and send it to you.
Okay.
Are you missing all of them?
Or I just know, like, I think this past week, I wasn't able to try to, I did it at school and stuff, but I had a hard time pulling it up at school.
Okay. I will look. Yeah, I'll look at how it was saved and I'll resend you. I'll just resend all of them. I'll try resaving them as a different file type.
Okay. I was like, I also know when you redid the review, I don't think you noticed that your screen had stopped screen sharing.
Oh, okay.
So your whole lecture was without the screen share.
No.
Yeah, it was without the so the PowerPoints disappeared. So everything was just you talking and no PowerPoint.
Lovely. I'm glad you said something to me. So I will resend all of them to you as a different file format.
Okay.
Thank you. You're welcome. Have a good day.
Are we done?
Yeah, you're good to go. Yeah.
Okay. Thank you.
All right. You're welcome. Bye-bye.
Bye.
Yes. Got it.
All right, Tiffany, are you plugged back in? Are you ready, Tiffany?
I connected my laptop.
Yes, ma'am.
Okay, let me see here.
I connected my laptop to my hotspot. I was like on number 7 and everything just stopped.
Oh my goodness. All righty. Let's see here. I should be able to fix it while we're on the phone or on the line here. Let's see. Let's do. Okay, so that should have fixed it. You should be able to go back in, but obviously if it didn't work, let me know.
Okay. Okay, it let me resume on number 3, so I can just go ahead and finish from there.
Yeah.
Is that what I need to do? It says resume.
Okay, then go ahead. Yeah.
Okay.